Good morning. It's my pleasure today to speak about the histopathology of lupus nephritis. What's new this year? So this presentation will include the 2 slides for introduction. Then I'm going to answer 2 important questions. What was already known about the histopathology of lupus nephritis? Then what's added this year, 2018, for the diagnosis and the revision of the already known classes of lupus nephritis, and I'll end with 2 questions. Let me to start with this slide. It is a very important topic, lupus nephritis, and this is why if you go to the ESNT Virtual Academy, you will find more than 40 lectures and 16 videos. So this video of diagnosis is important because it included the diagnosis from the biomarkers and the pathology. So this is an important resource for nephropathology. This is the updated book of Professor Hussein of this year in the course, in the 3rd annual nephropathology course that was held between 21 to 23rd March 2018 at Mansoura New General Hospital. And this is the nephropathy. The chapter 16 is the nephropathy of systemic lupus erythematosus, and also find the lupus nephritis histopathology within this book as well. So what was already known about the lupus? I'm going to start with the question, what about the spectrum of lupus nephritis? Lupus can affect all components of the kidney. Glomeruli by immune complex glomerulonephritis. Post-immune it is very strange to speak about post-immune no deposition within lupus nephritis, but this is one of the categories. Rapid progressive glomerulonephritis, turbulent recessive lupus nephritis, vascular lupus nephritis, and under vascular you can find antiphospholipid nephropathy, vasculitis, renal vein thrombosis. This means that all components of the kidney can be affected by pathological process in lupus nephritis. Regarding WHO classification, what is the most common class? We have 6 classes. Class 1, no change by light microscope. Then class 2, mesangial. Class 3, focal proliferative. 4, diffuse proliferative lupus nephritis. 5, membranous, and 6, advanced sclerosing. So these are WHO classification of lupus nephritis. What is the most common class? All through the years, class 4 is the most common, which is diffuse proliferative, and the most active class of lupus nephritis is class 4, as you see in this slide. So proliferative lupus is common, principally class 4, followed by class 3, as you see in the current era of the lupus nephritis. Regarding the different classes, class 1 is principally normal appearing renal histology. So this is the glomerulus, normal glomerulus from up to date, and this is from Professor Fatma. You can find here the capillaries are normal, mesangial cells are normal, just 1 row of cells or 2 rows of cells. So this is normal appearing light microscopic findings. So how can we say class 1 is by immune fluorescence? So you can find by immune fluorescence some deposits here or there. So this is the diagnosis. Diagnosis of class 1 is by immune fluorescence. Class 2, here you can see the great difference between class 1 and 2, mesangial expansion and the proliferation. All these are the nuclei of mesangial cells. You can find multiple rows of the mesangial cell, so it is proliferative within the mesangial proliferation and thickening. So this is class 2. You can find here mesangial deposits of immune complex. Regarding class 3 and 4, in class 3 and 4 you can find active or chronic lesions. So active lesions, just for enumeration, you can find mesangial proliferation. So here, multiple nuclei of mesangial cell and mesangial expansion. Hyaline lesion, this means the membrane is thickened, it changed into wire loop appearance because of subendothelial deposits. and by electron microscope you'll find the subendothelial deposit, and you can find also hyaline thrombi. This is one of the most florid active lesions, which is cellular crescents, because here the tuft is compressed by this cellular crescent. So this is the most important active lesion. Cellular crescents here is very clear. So this is the active lesion. This is Caryorhexis, was considered before 2018 to be an index of necrosis. Fibrinoid necrosis, and this is a special stain, phosphotongestic acid hematoxylin stain showing the fibrinoid necrosis, and this is also one of the most florid lesions, cellular crescents and necrosis. Both of them are very important active lesions. And then this is the neutrophil infiltration, hypersegmented neutrophil within the capillaries of the glomerulus. So this is the neutrophil infiltration. And the last active lesion is the interstitial inflammation. So we have 6 lesions within the active lesions: mesangial proliferation, hyaline lesion, cellular crescents, necrosis, neutrophil infiltration, 5 active lesions within glomeruli, and tubular interstitial inflammation within interstitium. Chronic lesions are 4 lesions, either sclerosis, tubular atrophy, the tubules are not back to back with some casts, and then some fibrosis between the within the interstitium. So tubular atrophy is one item, in fibrosis one item, sclerosis one item, and the fourth chronic lesion is the fibrous crescent. So these are the 4 chronic lesions. This is proliferation, and this is the immune complex deposition within the tissues of the renal pathology. You can find within the capillaries IgG, C1q, IgM, and the dominance is IgG, and you can find C1q. Regarding class 3 and 4, class 3 is focal proliferative. So proliferative process affects less than 50% of glomeruli, diffuse proliferative more than 50%. So then before 2018, each class was sub-categorized into A active, A and C active and chronic, or C chronic. Class 4 is further subdivided into segmental, so part of the glomerulus is affected by active lesion, or all the whole glomerulus is affected, global, active and chronic lesions. So these are the subclasses of class 3 and 4. Class 5, before I'm going to class 5, regarding the electron microscope of class 3 and 4, this is a normal appearing capillary. So this is a lumen, endothelial cell, basal membrane, and epithelial cells, podocytes, food process. So no deposit here within the normal. This is a normal glomerulus, and here this is the subendothelial deposit, which is the characteristic of proliferative lupus nephritis. And here I appreciate all the sincere efforts of Professor Helmut Rinke at Harvard Medical School. The pathologists read the histology, so any lesion, either active or chronic, is scored into 1, 2, or 3. If it affects less than 25% of the core, it is offered 1 point. If it is between 25 to 50%, the score is 2 points. It's 3 points if it is above 50%. Active lesions are mesangial proliferation, hyaline lesions, cellular crescents, necrosis, neutrophil infiltration in the glomerulus, and then interstitial inflammation. If you give the maximum score, then the activity index will be 18, but we know the activity index is from 24. How comes? Because cellular crescents and necrosis are multiplied by 2, because they are the most important active lesions. So the total activity index is 20 from 24. Chronicity lesions are 4: sclerotic glomeruli, fibrous crescents, atrophic tubules, interstitial fibrosis. Each lesion, if we give the maximum score for each lesion, then the full score of chronicity is from 12. So it is important to look at the pathological indices. If you have very high activity and very low chronicity, this means that the disease is active. And vice versa, if you find the activity index is low and the chronicity lesion is high, this means that chronicity is there. Class 5 is membranous lupus. You'll find by silver stain this vacuolar appearance because the deposits don't take the stain, the silver stain, and the deposit is mainly subepithelial, like idiopathic membranous, and you can find in lupus as well some subendothelial deposits. Here, this is an interesting article by Professor Fatma Hussein looking at the podocyte detachment. And in this study, the Professor Fatma et al. Found that podocyte detachment is correlated with activity of lupus. So this is the normal appearing glomerulus antipodocalixin, which is the stain for podocytes, shows the nice appearance of podocytes that decorates everything, so it's very nice by antipodocalixin and colloidal iron. Look here, for lupus nephritis, you'll find detachment of the podocyte within Bowman capsule. If no detachment, the score is 0. If less than 3 podocytes per glum, it is 1. 3 to 5, 2. Above 5 podocytes per glomerulus, the score is 3. If we add these 3 activity points to the 24, then the activity index may be from 27. But up to this point of time, still activity index is from 24. Sometimes you can find positive anti-neutrophil cytoplasmic antibody in a patient with lupus nephritis. In this study, they showed that it may be correlated with aggressive histology like recurrence and necrosis, so to put in mind. Antiphospholipid nephropathy, the pathologists can think of antiphospholipid nephropathy if they found a double contour appearance, healing phase, or here hyaline thrombus within the capillary, or this structure, this is the capillary aneurysm because of mesangiolisis. So if the pathologist commented on these points, we test for antiphospholipid and we may consider anticoagulation for these patients. You can find a patient with lupus nephritis and the pathology is vasculitis. And here this is a very nice term, which is lupus podocytopathy. Although it is rare within the histology of lupus nephritis, and the patient presents with nephrotic syndrome with or without acute kidney injury, and the histology by light microscope will find minimal change, mesangial or focal and segmental glomerulosclerosis, and these are the criteria. Clinically, the diagnosis of systemic lupus, nephrotic range proteinuria, often accompanied by acute kidney injury, no history of nephrotic medication, of nephrotoxic medication like non-steroidal prior to the onset of renal disease. Light microscopy, glomeruli show minimal change, mesangial proliferation or focal segmental glomerulosclerosis patterns without subepithelial or subendothelial deposits, excluding glomerular scar or proliferative lupus nephritis in the FSGS pattern. Immune fluorescence, the absence of capillary immune deposition with or without immunoglobulin and complement deposition in the mesangial area. Electron microscope, effacement of food process in more than 50%, typically 70% with mesangial dense deposit, and in the absence of subepithelial or subendothelial dense deposit. To diagnose lupus podocytopathy, this is the most important statement. We should find these 4 criteria together. So the diagnosis is met if all the criteria are met for the diagnosis. Some interesting point, which is silent lupus nephritis. This means clinically no active disease, but the biopsy shows active pathology. So the other name is anephritic nephritis. So we can find this point in the pathology. So the lupus nephritis was histopathologically identified in 75% of systemic lupus erythematosus patients without abnormal urine analysis or renal impairment. Low complements and high titer of antibodies were identified as predictors of silent lupus nephritis. To the contrary, this is another interesting point, which is renal limited lupus like nephritis. And the difference between renal limited and this, the silent lupus nephritis. In silent lupus nephritis, you can find complement abnormality and anti-Smith antibodies, but here the serology is negative and the pathology is within the tissues. So the other name is seronegative lupus nephritis, but it's still rare. Regarding recurrence, this slide summarizes the recurrence after transplantation for all types of glomerulonephritis. If you look at systemic lupus erythematosus, the risk of recurrence ranged from 2.4% to 41.6%. And here, the risk for graft failure is 14%. But regarding the histology of recurrence, is it necessary to be the same like native pathology? The answer is not, because of the use of immune suppression after transplantation. So you can find the native pathology is class 3 or 4, and you can find recurrence by class 2 lupus nephritis. This is expected because of the use of immune suppression. So the class of lupus nephritis after transplantation may be the same or lower grade class. Regarding the classes, you can find even for biopsy, you can find class shift and class drift. What's meant by class shift and drift? This is for native pathology. Class shift means if you repeat the biopsy, you'll find more aggressive lesions. Class drift, less aggressive lesions. Regarding Interobserver Agreement, this is a very interesting point, and this is why we should train the pathologists to read, because the senior pathologists have a good agreement in comparison to junior one. Regarding the doing biopsy for a patient with systemic lupus erythematosus, renal biopsy is indicated in all these recommendation authorities if there is proteinuria either above ½ gram or above 1 gram. So there is agreement between all nephrologists. If you have a case de novo systemic lupus erythematosus with any renal manifestation, biopsy is needed and indicated, except if there is clear contraindication for doing the biopsy. But there is no agreement between different nephrologists regarding repeated biopsy. A repeated biopsy just for surveillance is not indicated up to this point of time and still debated, but repeated biopsy can be indicated if there is worsening or flare up of lupus nephritis. Regarding some interesting point regarding repeated biopsy, clinical pathological features of repeated biopsy in this slide. Here, the majority of proliferative lupus nephritis, after repeating the biopsy, you will find the pathology the same. So the majority of proliferative stayed proliferative, but some of the non-proliferative may be shifted into proliferative, and this is class shift. This is a very interesting study, showed that you can find histological remission with apparent clinical activity and vice versa. So the patient may have the clinical remission and still you'll find the pathology, active pathological lesions. So up to this moment, it's still investigational to do repeated biopsy after 6 months or 12 months to shift from induction to maintenance. This area needs many research, and currently we have MD thesis about this issue in our center. So this is just to show you that the nephrologist may think of rebiopsy. So even in sustained remission, we can do biopsy to taper or discontinue immune suppression. If there is complete clinical response and there is flare, and the reference biopsy was class 3 and 4, or 3 and 4 plus class 5, rebiopsy may not be necessary in this situation. But if the reference pathology is class 2 or 5, repeated biopsy, because you can find the class shift, as histology may have changed. If the patients If the patient is treated with partial clinical response, rebiopsy may show resolution, so no treatment needed. No response or worsening kidney function, rebiopsy may show scar, so no treatment needed. No response from the beginning and persistent nephrotic proteinuria, rebiopsy may not be necessary. It is just intensified treatment. So this is, I think it is a very rational algorithm for repeated biopsy. The situation in pregnancy is very difficult to do biopsy or not. However, we should be cautious. Biopsy as early as possible if any of the following are present. Increase in serum creatinine that cannot be attributed to some other cause. Proteinuria above gram. Proteinuria above half gram with concurrent hematuria or cellular casts. So these are the indications of biopsy in early pregnancy. Consider biopsy proteinuria above half gram, creatinine and abnormal serology positive anti-WSNA, low complement and phospholipid antibodies. Confirm fetal viability on ultrasound before and after biopsy. Minimize bleeding risk. Monitor coagulation factors and platelet counts. Hold aspirin and fish oil for at least 1 week before the procedure. Don't biopsy if risks of stopping anticoagulation are too high, like history of arterial thrombosis. Avoid biopsy beyond 28 weeks of gestation. A biopsy not possible. Consider starting empiric therapy with possible biopsy in the postpartum period. And here I want to add, if the intervention doctor is not confident of doing a biopsy for pregnant lady, it's better not to do biopsy. What is added this year for all these criteria for lupus nephritis diagnosis is one of, it's just fine. This article shows tubular interstitial damage predicts end-stage disease in lupus nephritis, and it is very rational. Tubular interstitial damage doesn't mean proliferation, interstitial inflammation, it means interstitial fibrosis. So it is rational that if interstitial fibrosis is significant, the time for end-stage kidney disease will be short. But the most important informations that are published this month in the Kidney International issue of April 2018, the revision of International Society of Nephrology, Renal Pathology Society classification for lupus nephritis, and what happened, clarification of definitions, and modified National Institute of Health Activity and Chronicity indices. So the activity and the chronicity indices, as I mentioned in the first part here, endocapillary hypercellularity. This is the preferred term. This is it was used as endocapillary proliferation. It may not be endocapillary proliferation, and it may be just a representation of cellular infiltration. So endocapillary hypercellularity replaces endocapillary proliferation, and this is the score 1, 2, 3. So the score is 0 to 3. Neutrophil and karyorrhexis. So karyorrhexis is put within the neutrophil infiltration because they found that karyorrhexis is a reflection of apoptotic neutrophils. So it is not within necrosis but with neutrophil. So neutrophil or karyorrhexis again from 0 to 3. Fibrinoid necrosis stands alone for a reflection of necrosis, and the score is multiplied by 2. Hyaline deposits from 0 to 3. Cellular and fibrocellular crescents, cellular and or fibrocellular crescents, and the score is multiplied by 2. Interstitial inflammation is scored from 0 to 3. So these are the modified activity index, including these 6 points. Again, endocapillary proliferation is replaced by endocapillary hypercellularity. Here the karyorrhexis is put with neutrophil, and fibrinoid necrosis stands alone for the necrosis. Chronicity almost the same. Glomerulosclerosis score, fibrous crescents, subatrophy, interstitial fibrosis, so chronicity is the same. But here, this is the most important point is here they omitted activity and the chronicity. Just to put the score without saying class 3 active, class 3 chronic, just say activity and the chronicity index without AC, and also GS global and segmental subcategorization is omitted. So don't say A, C, A and C, and also don't say G or S global or segmental. And the activity index was restricted to class 3 and 4. Nowadays, it can be done for all classes, to be done for all classes. More important, if you go to this article, you will find the clarification of definitions. So in class 2, definition for mesangial hypercellularity adjusted: 4 or more nuclei fully surrounded by matrix in the mesangial area, not including the hilar region. In class 3 and 4, as I mentioned, endocapillary proliferation is replaced by endocapillary hypercellularity, because this may be a reflection of infiltration. The term crescent is used for a lesion consisting of extracapillary hypercellularity composed of variable mixture of cells, fibrin and the fibrous matrix may be present. 10% or more may be present. 10% or more of the circumference of pulmonary capsule should be involved. Crescents more than 75% cells and fibrin and less than 25% fibrous matrix. Fibrous crescent more than 75% fibrous matrix and less than 25% cells and fibrin. Fibrous crescent between 25 to 75% cells and fibrin, and the remainder fibrous matrix. So please go to the details. You'll find everything. Fibrinal necrosis, fibrin associated with glomerulus membrane disruption and or lysis of the mesangial matrix. This lesion doesn't require the presence of karyorrhexis, as I mentioned. Elimination of segmental and global subdivision of class 4. Modification of NIH lupus nephritis activity and chronicity scoring system to be used instead of the currently used A, C, A and C parameters. So this is very interesting points. So this is here you can look at the different pathology: mesangial expansion, proliferation, crescents. Here the fibrous crescents, and then the adhesions. Regarding the classes, this is class 1. You can find some scattered immune deposit. In class 2, mesangial proliferation and the mesangial deposits. Class 3 and 4, focal and diffuse proliferative with subendothelial. The hallmark is subendothelial deposits. Class 5, membranous subepithelial deposits, and you can find class 3 and 4. So you can find subepithelial of class 5 with subendothelial class 3 and 4. Class 3 and 4, so you can find all these combination. There is a trend toward omitting class 6 because it doesn't add any sense. So this is regarding the what is added. Regarding questions, so up to this moment, I summarized what is already known about lupus nephritis diagnosis from histopathological perspectives, and also what is added this year to the definitions and diagnosis. Let us go to this example of questions. A 35-year-old lady present to her nephrologist with hematuria, proteinuria, and deteriorated kidney function. Urine analysis revealed microscopic hematuria 30 to 50, red cell per high power field, proteinuria of 4 gram, creatinine 2.5 milligram per deciliter. Serology was positive for lupus. She is subject to renal biopsy. What the expected class of lupus nephritis? From this presentation, you can say class 4 because a lot of activity are there. So you can say class 3 or class 4 lupus nephritis, but it is mostly class 4. If the biopsy findings are 60% crescents, no necrosis, 70% haline lesion, 70% mesangial proliferation, 30% interstitial inflammation, 20% neutrophil infiltration, glomerulosclerosis 10%, and interstitial fibrosis 10%. Calculate activity and recurrence indices. If you review, 60% crecrescence, this means the score 3 multiplied by 2. So just crecrescence in 60% means 6 points. No necrosis, 70% hairline lesion, another 3. So 6 plus 3 equals 9. 70% mesangial proliferation, another 3. So the score up to this moment is 12. 30% interstitial inflammation, 2 is 15. 20% neutrophil infiltration. So the total activity index is 16 out of 24. Glomerulosclerosis in 10%, it's 1. Interstitial fibrosis 10%, 1. So chronicity is 2 by 12. So we have here activity 16 from 24 and the chronicity 2 from 12. What I want to say at the end is it is better to correlate these knowledges, this knowledge with the clinical practice, because knowledge is of no value unless you put it into practice, and the great aim of education is not knowledge but action, and we need a correlation and cooperation between different specialties, nephrologists, pathologists, and laboratory medicine. This presentation, I presented these slides within the Glomerulonephritis Day that was held at the Egyptian Medical Syndicate 3 days ago on the Wednesday. So I'm happy by resuming the activity of ESNT continuous medical education with all the members here: Professor Hana Hafiz, the President of Egyptian Society of Nephrology and Transplantation; Professor Hussein Fishawi, Professor of Nephrology at Qasr Al-Aini; Dr. Muhammad Abd Gawad, Dr. Karim Salim, and Dr. Muhammad Kamal Nassar, Professor Tariq Medhat. So with our colleagues. So it was very fantastic day, and we repeat these days every month. Every month we will discuss a special chapter of nephrology. And thank you for your attention, and I'll be happy if you have any questions.